I'd like to welcome everybody tonight to AO's webinar, Spine North America. We're going to be discussing post-op infection, discitis, and osteomyelitis. My name is Nick Spina. I'm an orthopedic spine surgeon here at the University of Utah. I don't know what it says about my practice or my surgical skills that I'm asked to moderate a session on post-op infection, but it is something I think we all have experience with, and a topic that's interesting to talk about. I have two of my friends and colleagues here with me, Dr. William Ryan Spiker from here at the University of Utah, and Dr. Jeremy Shaw, who's at the University of Pittsburgh, my old stomping grounds from residency, and I wanted to thank them for both participating tonight. These are our disclosures. Dr. Spiker and myself do not have anything relevant to this talk, and Dr. Shaw has a couple things relevant to the treatment of post-op infection that he'll talk about. As AO North America, we are an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. We do not endorse or promote the use of any products or service of commercial entities. And equipment used in this course is for demonstration and teaching purposes only, with the intent to enhance the learning experience. Just as a reminder, please turn off all your microphones. They've been muted and your video cameras have been turned off. There is a question and answer box, which you can feel free to chime in with questions at any point during this, and we'll address them at the end of each talk. And the chat box, which is in the bottom of the screen, is only for the faculty to communicate. So just as an overview, surgical site infections, universal problem for spine providers, poses a massive healthcare burden. And although guidelines exist, there's pretty lack of high quality evidence with regards to the treatment of this. And so the goals of this session are to understand the controversies in spinal surgical site infections, develop an understanding of the diagnosis, prevention, and management, and then gain some exposure to future directions, sort of the directions that we're moving in the treatment and diagnosis of SSI. And so brief agenda, we're going to use a case kind of intertwined, intermingled throughout the whole entire talk, just as sort of a background. I'm going to talk about prevention and optimization. Dr. Spiker will then talk about the diagnosis, both early and late infections. And then Dr. Shaw is going to talk about treatment and new trends in management. Depending on how long that goes, we also have time for a second case discussion. It's a patient of mine that's somewhat complex, and I think it'll generate some interesting talk. So to start with the case presentation, this is RL. He's a 62-year-old gentleman with symptoms of progressive cervical and questionable thoracic myelopathy, as well as intractable back pain. When he stands, he feels significantly hunched forward. He's been complaining of difficulty with hand dexterity, as well as balance issues that have been progressive over the last year. To my dismay, he's had multiple lumbar and anterior cervical surgeries. He had only relevant medical history other than spine is that he has a surgical history of a splenectomy that was done when he was 12. And following one of his last lumbar operations, he was treated for questionable cervical osteodiscitis with 6 weeks of antibiotics at an outside hospital. And per all reports, that was resolved. And so here are standing films, a lateral standing film, full-length scoliosis film. He's had multiple lumbar operations. He's fused from T10 to L5 with subsequent hardware removal at L5. He's got proximal junctional disease with significant thoracic kyphosis, as well as forward posture. You can see on the lateral of his C-spine, he's had a 4, 5, 6, and 6, 7 ACDF. 3, 4 is essentially auto-fused, and there's a flight spondy at 2, 3. And so when you look at this C-spine MRI, you can see that he has significant stenosis at C2-3, which is severe on the axial. He's also reduced. And then you can also see at the junction of where his previous hardware stopped, he might have a hint of a spondy on the thoracic, as well as disc herniation and some ligamentum buckling there with tight thoracic stenosis. So just to summarize this straightforward case, this guy has cervical and lumbar ASD with severe 2-3 stenosis, as well as severe 9-10 stenosis with sagittal imbalance. So when I saw this guy, I thought that he would require a stage surgery, given the fact that he had spinal cord compression at 2 levels and the magnitude of surgery that he would need. I planned on staging it. I wanted to take care of the C-spine first. And so I planned to move ahead with a C2 to T4 posterior cervical fusion with a 2-3 laminectomy, and then plan at a second stage to hook him up from T4 down to the pelvis with a few osteotomies to gain sagittal correction. And in thinking about this case, really, what we all want to do when we think about surgical site infections is try to prevent this from happening in the first place. And why do we care about SSI? Well, the overall incidence is not zero, unfortunately, and it depends on what you're doing and whether it's a revision or primary surgery. It depends on the definition you use in terms of what SSI is. But the incidence in the literature is anywhere between 1 and 13%. For all of us, it creates a burden on the healthcare system. The costs are estimated anywhere from a single episode of $15,000 to $38,000 for complex adult spinal deformity. This requires ED visits, readmission, surgery, postoperative antibiotics, and closer follow-up. Not to mention that all of our patients do worse for a while. And so this was a prospective study, or prospectively collected study that looked at retrospective data in terms of how patients did after having a surgical site infection compared to those that did not, looking at both physical function and ODI. And what they showed was that at all time points leading up to 6 months, patients with an SSI had worse outcomes, both in physical function and ODI. They were about 5 points worse in ODI and significantly worse in physical function. And so a postoperative SSI really sets the stage for a slower recovery and potentially worse outcomes. What's good to know about this study is that by 1 and 2 years, if you get the patient through the infection, the outcomes are comparable between groups. And so we can always counsel our patients, if this does happen, that once we get them through the infection, they'll do just as well for the most part. And so when you think about surgical site infection and prevention, you really want to think about risk factors. And there's 2 risk factors and whether they're modifiable. There's patient-specific risk factors, and we'll talk about those. And then there's factors related to the surgery. And this was a nice AO spine paper published in the Global Spine Journal that looked at surgical site infection in spine surgery and who is at risk. And I wanted to highlight, it's a retrospective review. And if you look at the type of studies included, we don't have a lot of great high-level evidence in terms of risk factors, treatment, or management of surgical spine infections. There's a ton of cohort studies. There's a couple matched cohort studies, matched paired cohort studies, case control studies, case series. There's really no prospective randomized studies. And the difficulty in doing this is it's hard to boil down SSI, which is such a complex being, to one factor that we can change. And so it's such a multifactorial, multi-dependent occurrence that it's really, really hard to study. And so what they did after looking through all of this was identify specific patient factors that showed a strong association with increased rates of surgical site infection. There are the obvious ones, and we all know that smoking is bad. Current smokers, as well as smoking at any point, had higher rates of SSI compared to their non-smoking cohorts. We know that diabetics are at increased risk for surgical site infection. Obesity, in some studies quote obesity over the BMI of 30, but if we listen to that, Jeremy would not have a practice in Pittsburgh. And other studies really define that as less than 35. Where the obesity is also matters. There's several studies that look at the fat thickness on supine imaging on MRI and show that there's a significantly increased risk of SSI if that fat thickness is greater than 50 millimeters. And other studies have quantified that for every millimeter, there's a significant increase in the risk of surgical site infection. Nutrition is also a big one. In terms of surgery and surgical factors, there's really a mixed bag in terms of what's important. We think that longer operative times, longer open wounds are probably place patients at increased risk. We also know that surgical invasiveness, which really is, how many levels are fused, osteotomies, more difficult procedures, revisions, these patients are often at increased risk for surgery. And so when we think about preventing SSI, we think about those risk factors and what are modifiable. And you can largely define prevention in terms of what you do preoperatively, what you do in the OR, and what you do postoperatively. So for pre-op, we'll kind of walk through a couple of these and the studies that have been done. And really, anytime I do a huge case, or I'm thinking about doing a larger case, or somebody that doesn't pass sort of the orthopedic eye test in terms of health, I always like to check nutrition. There's been studies that look at both albumin and pre-albumin in terms of the rate of SSI, and Bull et al. In 2016 looked at 1 to 3 level fusions. And in this cohort, they compared patients who were hypoalbuminic as defined by an albumin of less than 3.5, compared to those who were normal albuminic or greater than 3.5. The overall rate of hypoalbuminemia was about 5% in this population. So not very high numbers, but there was a significantly strong increase in surgical site infection in this group. The problem with albumin is it's slow to turn over. And so a group out of Pittsburgh, the neurosurgical department, thought maybe we should look at pre-albumin, which turns over in about 2 days. And what Salvetti showed in the Journal of Neurosurgery in 2018 was that if you were less than 20 with pre-albumin, your odds ratio for SSI as compared to greater than 20 was 3.28. So it placed you at significant increased risk of SSI. And so this is somewhere that we can intervene in these high-risk patients. And obviously, when you think about patients, the C2 to the posterior cervical surgeries, the bigger posterolateral thoracolumbar surgeries, those surgeries, you're more worried that you're going to wind up with an SSI compared to what maybe say an ACDF. And so I don't check nutrition labs on all patients, although it's not a bad idea. When it comes to diabetes, we know that it influences the risk of SSI as well as outcomes in spine surgery. The question is, what should be the appropriate cutoff be in terms of saying somebody's able to proceed with surgery? And really, there's a couple studies in the spine literature ranging from 7 to 8. Chang et al., and this was out of the Michigan Spine Registry, showed that an A1C greater than 8 was associated with a higher 90-day readmission, higher rate of complication. And so in my practice, if I'm doing a large surgery, I really use an A1C cutoff of 8. And I like to see either a downward trend getting to 8 or consistently being under 8. In terms of more strict cutoffs, a recent study that looked at cervical spine surgery out of Vanderbilt showed that A1C greater than 7.6 was associated with higher rates of readmission, 6.8 associated with reoperation, and any A1C over 6.1 was associated with failure to reach MCID. 6.1 is a pretty aggressive target, but it's not just postoperative complications, including SSI. We also probably want to think about achieving a good outcome. And then finally, Hakata et al. In 2014 looked at the small number of patients, and I'm always worried when there aren't any surgical site infections with a certain cutoff. But in patients under 7, they showed no SSI compared to patients greater than 7 in A1C had a 35% rate of SSI. And so depending on how strict you want to be, you can wind up in the literature between 7 and 8. What can we do in terms of nasal decolonization? And this is a kind of a controversial but pretty common practice. I feel like this was a meta-analysis that looked at nasal colonization of Staph aureus preoperatively and what the influences was on surgical site infection. They pulled 7 studies, about 10,000 patients, and what they showed was that testing the nose 5 days prior to surgery, if there was colonization with MSSA, there was no association with surgical site infection. When there was colonization with MRSA, the relative risk of surgical site infection increased to 2.52, and this effect disappeared if those patients were treated if they were MRSA positive. This seems to indicate, as well as several other studies in the literature, that if you decolonize a patient with treatment of mupirocin, 2% nasal ointment prior to surgery, if they are colonized with MRSA, it's probably a good idea. Now, what this study didn't talk about is MRSE, which is on the uptick in terms of surgical site infections. People also talk about using chlorhexidine wipes or chlorhexidine showers. There's been a couple large Cochrane database reviews which don't show much of an effect. This was a study published in the spine literature out of UCSF that showed that there was a significant decrease, at least in their laminectomy or non-fusion cohort, compared to a control group that weren't treated with chlorhexidine showers, and in a relative risk reduction in surgical site infection. Interestingly, in the fusion group, they saw no difference between the shower group and the non-shower group. But when they did a multivariate logistic regression or controlled analysis, that significance showed up again. And so their recommendation was it's a low risk intervention. It may reduce surgical site infection and is probably recommended. Interesting, the same group did the same study in craniotomies, and they showed no difference. And so in our practice, or in my practice, I do both nasal swabs as well as a recommendation of chlorhexidine wipes over the surgical site prior to going through with surgery. When we think about intra-op, really there's three areas that we can talk about. One is skin prep and antibiotic. So skin prep, there's really no skin prep that's better than others. There's a couple studies that show that anything that's alcohol-based, ChloraPrep or DuraPrep, is probably better than a iodine or a betadine-based solution. But between those two, there was no difference in a prospective study. In terms of antibiotics, there's some controversy, at least old school controversy, in terms of if you leave a drain, should you leave patients on antibiotics for greater than 24 hours? A prospective randomized study showed that this was not necessary. And so really the recommendation is for 24 hours of preoperative antibiotic, or one dose of preoperative antibiotics followed by 24 hours of postoperative antibiotics. In terms of other things that we think about in orthopedics, our joint colleagues always like to put that nice green sign on the door that says total joint in progress. Please do not enter. There probably is some worth to controlling the influx and into your room, or the amount of times the door opens. This has never been showed in the spine literature with regards to fellow presence or resident presence. OR time can be associated as a factor for SSI, so try to operate efficiently. And then the question of how often you should irrigate and what you should irrigate with comes into play. Really, the only solution that's been shown to decrease SSI in several studies is providine-based solution, and this would be a dilute solution of that that's used. There was one study out of Japan that looked at irrigating with 2,000 mLs per hour, and that showed a strong association. I don't know that I've ever irrigated with 2,000 mLs in an entire case, let alone every hour of a deformity. But that showed a strong association P of 0.08 in terms of reducing SSI. And then the final thing we do, which has a little bit of controversy around it, is intra-wound antibiotics. And it's become really a common practice. And there's been several prospectively collected data as well as retrospective studies. One out of Pitt that you can see here at the bottom, that was a single surgeon series that reduced the historical infection rate of about 5% down to about 2%. The paper that's listed on top was prospectively collected data, and they showed that in a surgeon selected, or when the surgeons were able to select whether to use Vanco or not, and you compared those two cohorts, there was a significant reduction in SSI. And so Vanco appears to reduce SSI, but at what cost? And this was a recent meta-analysis to look at, does it affect the biologic milieu or the bacterial milieu in lumbar wounds? And what they showed was that, it probably does reduce the SSI. They pooled results of 11,000 patients in a control and 9,000 in the Vanco group. They had 3.8% in the control and 2.3% in the experimental. While this wasn't significant, there was a significant trend, and the relative risk reduction for Vanco was 0.62, or the number needed to treat to prevent an infection was 67. But what they also showed was that in the group treated with Vanco, there were many more gram-negative infections, and the relative risk of a gram-negative infection was 1.93 compared to control. And so when we put Vanco in wounds, we probably are changing the bacterial milieu. We probably are placing patients at increased risk for a gram-negative infection compared to gram-positive. And so I think Jeremy will talk about what antibiotics are probably ideal to use, and maybe cover this a little bit. Is Vanco the best option? And so do we have prospective randomized controlled trials? Well, there just was one published in the European Spine Journal comparing posterior thoracolumbar surgeries with and without vanco, and there was no difference between the groups. Essentially, the use of vancomycin powder did not affect the rate of SSI, but it did increase the number of gram-negative infections seen. And so talking about postoperative, can we affect postoperative measures to minimize surgical site infections? And I like this quote out of the paper. The main conclusion of this retrospective review study was that there is currently no good evidence in multiple domains to support any postoperative measures as a way of reducing SSI in spine surgery. And so it doesn't really matter what type of suture you use. It doesn't matter what type of dressing you put on. Really, there is not enough literature to support doing any one thing. I will tell you that tight glycemic control is probably the one thing postoperatively that can reduce SSI. There's been some studies to show that early detection of UA and treatment of UA is useful in preventing surgical site infection. But overall, when you pull all the data, nothing matters. One thing that I have gone to using a little bit has been negative pressure dressings. There are some preliminary data in terms of the use of incisional wound vacs and the possibility of reducing SSI. They are costly, and so I tend to use them at high risk patients, but I do think that there is some reduction in prevention of the SSI. So take home messages for this portion of the talk. Prevention is key in the treatment of SSI. I think you need to focus on those modifiable patient factors, modifiable OR factors. The most important thing is developing consistency in your practice. It's hard to remember to do this on every patient, but getting your team on board, having your nurses or your hospital staff, MAs, know what your preoperative protocol is and do it on everybody. Vancomycin appears to help in reducing the rates of gram-positive SSIs, but not without cost. And finally, we need higher quality of evidence. And so that's sort of, a talk on prevention of SSI. I don't know if there are any questions in the QA.
I don't see any yet.
Okay, if they're not, then I'll just kind of move back to the case. So just to remind you of the case, this is what the MRI looked like. And I choose to do a C2 to T4 with the plan to hook up. And it went well. We had no complications. These are his x-rays. He came in for his 2-week appointment to have his incision checked. He had one fever the day before, had some increased neck pain. So we got some x-rays, which we typically don't do at the 2-week point. And I was actually on a plane out of town. This was right over Thanksgiving. And this was the picture that I got sent to me on the plane. And it looked pretty good to me. I thought there wasn't a lot of peri-wound erythema or any drainage from the wound. And I told them to take the sutures out. And maybe I'll transition to ask Dr. Spiker to now give a talk on sort of diagnosis. Because obviously this is a talk about infection. I wasn't suspicious about infection at this point, but the story will continue. And so I'm going to stop sharing my screen, and Dr. Spiker will jump on.
Excellent. Thank you, sir. Great talk. There was one question that came up there late about the role of maybe a plastic surgery closure, if you came across that in prevention of SSIs.
Yeah. I haven't read a particular paper that led towards any sort of high level of evidence that plastic surgeons are any better at closing primary spine wounds than spine surgeons. I think my general gestalt is that our plastic colleagues are very helpful in the treatment of SSI, but I don't know that they are helpful in the prevention of SSI. And I don't know how you guys feel about that.
Yeah, I would agree. I think Jeremy just typed in that he may discuss this during his section, so I won't belabor the point too much. But I would agree. I think in prevention, I don't think there's a role. In treatment, I think there absolutely can be. I would agree.
I would echo that. I will say I do ask the plastic surgeons to help me close wounds that I'm going to irradiate. So for the big tumors I do, where they're planned, and I'm able to get plastic surgery help, I will ask them to help me with those because it does reduce my risk of complications.
Or maybe Dr. Shaw just doesn't like to close those big incisions. We'll never know. We'll never know.
Yeah.
No, I think it's a great point. Well, thank you for the introduction, Dr. Spina. Great talk. A ton of data. I think the prevention part of this talk is really critical to everyone's practice, and excited to see 75 people joining us tonight. So thank you all for putting in the time for this important topic. I am given the task of discussing the diagnosis and imaging of postoperative spine infections. And so I want to thank Dr. Spina not only for the invitation, but I also stole some of his slides from a previous talk he had given. So thank you in both regards. My disclosures previously mentioned, not pertinent. To quote the Supreme Court, some things you know it when you see it. And I think early infection often falls in that realm. So when this patient shows up to clinic, the first year med student knows this is infected. That is not the point of my talk today. I think this is more the early infection that we're trying to understand. It's the early wound drainage, a little bit of surrounding erythema, no fever, a little bit of pain that's kind of waxing and waning, that's kind of normal postoperative. And how do we think about that patient? Because I think that's a patient that we all see and all have to make sometimes difficult decisions on. It's a little bit less clear. And so whenever you're kind of considering if it's an infection, you're also considering that it's not, meaning it could just be a suture abscess, it could be slow wound healing, it could be a patient that fell asleep, on a heating pad. I mean, there are a lot of things that make wounds not look good besides infection. And so you have to kind of, have a wide differential. But as soon as infection makes that differential, I think you owe it to yourself to kind of start the process of evaluation. And the reality is that in my hands has to be an in-person evaluation. And so we do some remote care. I'm here at the University of Utah. We have a big catchment area with patients that are hundreds, if not, sometimes 1,000 miles away, and they're often don't want to come back for obvious reasons. But this is somebody who has to come in because seeing it, touching it, feeling it really changes my treatment. And so, you order up the old history and exam, and that really guides a lot of treatment, I think, in this. The history part that I think I'm going to focus on is that recovery arc. And so people talk about the recovery arc when they're diagnosing like pseudoarthroses, where patients do better, and then at 6 months or 9 months, they start doing worse. And you can see that in the infection realm, where patients will do really well for the first week or 10 days, and then they'll have this progressive pain, this progressive new symptom. And if you really ask them about it, they'll often give you that history. Obviously, any new neurologic finding or progressive kind of pain or weakness needs to be evaluated and kind of consider that it could be infection. And then you always want to ask about systemic symptoms. And so sometimes they can be underwhelming, but just generalized malaise, as well as, fevers, chills, nausea, vomiting, things like that. And then if they have any other joint or medical issues. So, in this example that Spina brought up, there's a splenectomy. So, gram-negative encapsulated organisms are a little bit higher risk in that population, or they may have a history of other joint infections or current issues with their dentition or other things that lead them to be higher risk. And so we really have to think about the patient a little bit more holistically than we often do as spine surgeons. And then on a physical exam, you want to do a full neuro exam. Things like meningitis can be missed. And so you have to consider that this could be more than just a surgical site infection. This could be something that's progressed significantly. And then looking closely at the wound is obviously critical. When the exam is kind of equivocal, I think it becomes important to start thinking, well, what else do I have at my disposal? And that's where the labs and the imaging come in. And so the first thing is always, looking at it myself. And then after that point, then the labs are going to help guide me. I think if you just order labs on everybody, it can be a little bit hard to understand what to do with those labs. But in a patient that you've kind of set that has a high risk based on other things, then those labs really help you. And I also think this is a nice opportunity to optimize other medical issues. So we see infections not only from our own practice, but also from the surrounding areas. And it's an opportunity to get labs that can kind of optimize their healing. So looking at things like blood sugar, looking at their other medical issues at the time of the evaluation can really give you a jump start. And so if I'm seeing somebody else's patient, they had surgery a month ago, they have this draining wound, I'm going to try and optimize that as early as I can before I have to do some sort of a surgical intervention. And then imaging is kind of the last thing in my mind. And so X-ray, CT, MRI can all certainly be helpful, but it's a little bit kind of secondary for me most of the time. The ESR we know peaks around 2 to 5 days, but it normalizes around a month. CRP peaks a little bit earlier and it normalizes much more quickly, which is helpful. So usually these postoperative infections are happening around that 7 to 14 day mark. And so your CRP should be trending in the right direction. Certainly if it's trending up or if it's significantly elevated around that 10 or 14 day mark, that's going to guide me more than an elevated ESR. Procalcitonin and the neutrophil lymphocyte ratio have also been touted in some papers that can help predict surgical site infections or delineate people who are at risk. There are also studies like this that show that they don't accurately predict surgical site infections. And so the role for procalcitonin, I still order it. I still use it as part of my data, but I really led over time, kind of it's led me to follow the CRPs a little bit more closely. And then the neutrophil to lymphocyte count, anything over 65 to 70%, I think is helpful and kind of again leads you to that answer. None of these are a single test kind of giving you the answer. They're all leading you toward a diagnosis. And so you're collecting this data and then trying to incorporate it into your overall picture, what it looks like, what the patient's telling you, and all these lab values. This is a study that I included. It came out 5 or 6 years ago, but it kind of is one of the studies that led me more and more toward the CRP, because every study that's come out recently has really suggested that CRP seems to be more sensitive and more specific, even though these other things like lymphocyte count and calcitonin can have some role. They seem to be less predictive of infection and less specific. The imaging in the acute setting is often not helpful. In my practice, I'm really only getting an MRI in somebody in the acute setting if they have some sort of new neurologic finding or some persistent neurologic finding that's surprising to me. They had an acute ridic, they got better for 2 days, and then it came back, which could be classified kind of as persistent. It's not necessarily new, but it's worsening. Plain films for me do help the patient who has significant pain. And so I have had patients that I was concerned their wound looked a little bit questionable. You get x-rays and they actually have, an osteoporotic fracture somewhere. They have ASD, they have a sacral fracture. So there are lots of things that can lead a patient to have a lot of pain in that recovery arc that's suspicious for an infection. And then CT is really only if there are still questions that remain after those other imaging modalities. So if I'm evaluating a fracture, if I'm looking at hardware placement, but it's relatively rare in an acute infection for a CT to really guide my treatment. Drainage is something that often comes up. So if it's a fellow or a med student or a PA, it's, so-and-so called, they're still draining. What should we do? And the answer again is always, history and physical. And so those patients all get brought in to see them. Early drainage has been shown in a lot of studies to not necessarily lead to infection. And so this is a study on deformity patients, included a lot of pediatric deformity as well as some kind of younger adult deformities. And what they found was that early drainage was not predictive of infection, but any prolonged drainage more than 2 weeks, especially in the higher risk patients, led to a much higher risk of infection, and they suggested further workup. And so drainage for the first week, really common, starts lingering into the second week, is concerning, may want to see it. Anything over 2 weeks is kind of setting off alarms that I want to at least consider that they may have an infection because it's abnormal. So here's a patient, again, what we started with, normal ESR, normal CRP, normal white blood cell count, x-rays look fine, but have this kind of increasing pain, this wound. This is something that I'm going to see back. So I'm going to talk to him. If it's somebody I trust, somebody that understands kind of the situation, I'm going to see him back in a week and do local wound care and kind of go from there, which is obviously different than something that's a late infection. So I want to spend just a couple minutes. I'm going to make sure we give Dr. Shaw plenty of time here too, but talking about late infection, because it is a totally different beast. And so early infection, I think a lot of it becomes gestalt, and I think a lot of it's taught over your residency and your fellowship, and hopefully the things I talked about help guide that. Late infection is very different. So this is a patient referred to our facility from an outside surgeon who came in, months after this surgery. And so comes to the emergency room, is tired all the time, has this progressive low back pain, incision's fine, vitals are unremarkable, white count's 5, CRP is 106. And so you start with the same principles. You start with the history and physical. As soon as infection works its way into the deferential, this patient who's tired, has some systemic symptoms, has some concerning signs, that patient's going to start kind of getting the imaging in labs to rule out infection because it's on the differential. And I think it's just important to keep that in mind. You know, when you're thinking about it, just order the labs. And so these are the x-rays. X-rays look fine, nothing remarkable. I don't see any loosening, don't see any erosions, nothing that suggests a long-standing erosive infection. CT shows good incorporation of the grafts, shows a little bit of loosening at the top of the construct. Nothing overly concerning for infection, but maybe some pseudoarthrosis developing. No obvious fluid collection. And then the MRI becomes really helpful. There is a rim enhancing fluid collection. There's a lot of artifact around this instrumentation, but there's clearly kind of this collection. And so this is where suddenly just looking at the wound and talking to the patient may not be enough. In late infection, people present all over the map. Sometimes they're septic, sometimes they're just tired and really have nothing else that's pointing you toward infection. And so this is a case that I bring up just to point out the importance of kind of going through those steps in people with a late infection and considering the possibility. There are other ways in late infection that you can look for infection with imaging. And so this was a study just talking about using kind of functional PET scans, something that I don't commonly do in my practice, but something to consider in that patient with significant progressive back pain that appears to be around the instrumentation in the area of the surgery, but doesn't have proof of an infection otherwise. And what you'll see is these areas with a lot of uptake, much higher than the liver. Liver is usually around 4 or so. This is 7.9 in this study. It's really high uptake, which is really suggestive of infection and may lead you to biopsy and culture of this area and eventual treatment, which becomes obviously its own can of worms. And so I think you just have to be persistent with these late infections and really kind of look under every rock. There's no specific recipe for diagnosing postoperative infection. I think it really takes, you have to be a doctor. You have to have that clinical suspicion. You have to see those patients. You have to do a full physical exam and then really use the labs and imaging to kind of complement that history and physical, and then to kind of help guide treatment once you get to the diagnosis. Hopefully that's helpful. I think the reality is the diagnosis is probably the easiest of the 3 sections here. Preventing it is hard, and treating it is hard, and diagnosing it is often not that hard. But I'm certainly happy to answer any questions.
Great talk, Ryan. I think you touched on one of the questions that came up, and it was a question of indium scans in the treatment of or the diagnosis of infection, and really I think like you, PET CT isn't part of my practice, although I think it's become increasingly common in the diagnosis. And so unfortunately, this patient came back to me with a text message the next day when I was enjoying a pre-Thanksgiving meal, and his wound had pussed out. And he had frank purulent drainage, dehiscence in the mid portion. His white count, I think, was 23. His CRP was 16, and ESR was 60. And so obvious infection, and that's where we're going to ask Dr. Shah to discuss post-op infection and the treatment of this.
Also, thank you very much to Nick and Ryan for really excellent talks covering this topic, and thank you to all of our participants for joining us tonight. I have the dubious honor of talking about treatment of infection, of which I unfortunately have quite an experience with. I do have a couple of disclosures. I hold intellectual property related to the treatment of infection, and I also serve on the medical advisory board of Pergo Scientific that also makes technology relevant to the treatment of infection. I'm not going to really talk about this stuff tonight. I will also specifically talk about techniques that are supported in the literature and are considered standard of care in spine surgery, but are also off-label. And so I'm going to talk about that quite a bit. In terms of what we're doing tonight, really I want to focus on treatment. Nick and Ryan really covered diagnosis and really how to prevent infection. The treatment of this really leverages a lot of the same things that they talked about. So for surgery, we're going to talk about debridement. We're going to talk about perhaps eventual removal of hardware. We're going to talk about antibiotic therapies, systemic, local, as well as adjuncts. These are really principles that can be applied to treatment of post-op infection, osteomyelitis, discitis, and epidural abscess. And a lot of these things go hand in hand. I think the best treatment really, as was alluded to earlier, is prevention. So it's much easier to prevent an infection than it is to treat it. And managing the patient and host factors is really essential to success, both in the diagnostic stage and post-infection. So if you look at the pictures I'm showing off to the right, I mean, there really is not any treatment that I'm going to be able to do that's going to undo this problem for this gentleman. He's very large, he's diabetic, he's extremely obese, he does smoke, he's paradoxically malnourished, and he has multi-level osteomyelitis, discitis, and he's paralyzed. And so this is a very hard problem now to treat from a surgical standpoint. And when you kind of talk about this, you also start to understand that not all infection is equal. And I think Dr. Spiker talked about this a little bit. And chronic infection is very different than acute infection. These are not postoperative infections. The case on the left is an osteomyelitis, discitis, and epidural abscess. There's a little prevertebral abscess as well. This is a much more acute problem than the case on the right that has pretty substantial chronic erosive changes and bony destruction, which is nominally the same problem, osteomyelitis, discitis, and epidural abscess. So for simple problems, try and make the solution relatively simple. I think as long as you're going to acknowledge that these are problems that need to be treated, which to some extent is the first hurdle you have to clear. Acutely, you can try some antibiotic for brace for osteomyelitis, discitis, epidural abscess, as long as there's not a neurologic deficit. But really for chronic, refractory, or post-operative, and I'll include pretty much all post-operative infections in this bucket, you're going to be talking about surgery plus an antibiotic. And the rationale for why is because of biofilm. And so biofilm is something that occurs within hours to days. There's not a lot of evidence to suggest that there's any clinically relevant infection without biofilm present. It's present on the implants, it's present on the tissue. The picture off to the right is a Pseudomonas biofilm grown in a variety of implant materials, polyethylene, polyether ketone, cobalt chrome, and titanium. It's stained with methylene blue in this case. And also you can see scanning electron microscopy. You can see the gram-negative rods at the bottom of that screen. This is just one prototypical organism that occurs pretty commonly. And part of why this is important is because our understanding of biofilm biology has evolved. And there's this very historical construct which talks about biofilms protecting the bacteria from host immunity and antibiotics. And this is absolutely true. There's components in that biofilm that do that. But there's also a variety of bacterial phenotypes. And so one phenotype that's particularly problematic is this persister phenotype, which has actually been known about for quite some time. And this phenotype will tolerate really high doses of antibiotics. You can see this off in the graph to the right. It will then subsequently reseed infection regardless of the antibiotic. And so in order to eradicate it, mechanical debridement is really necessary. And this is not a new theory and has been used in general and plastic surgery for quite some time. Arthroplasty has really picked up this mantle, and spine, I think, is a little later to the party. But what needs to be debrided is biofilm and necrotic tissue. The necrotic tissue needs to go. It doesn't have any vascularity, won't heal. And the biofilm itself is relatively avascular. This is particularly true for what I'd call problem organisms, MRSA, MRSE, C. acnes, fungus, and anything that's polymicrobial, I think needs to be treated very carefully. In this, I like to use methylene blue. I think it's very helpful. It's an old surgeon's trick used to treat chronic wounds. You can see a non-healing wound up on the right. This is a general surgery or plastic surgery debridement. And then you can actually see this in an implant-associated infection where a hip capsule is stained in an arthroplasty. This is actually something I do in spines. And so you can see a pretty long segment reconstruction. This was a terrible infection with MRSA. This required multiple debridements. And in this case, I use going really from left to right to identify dead, necrotic, and non-viable tissue, methylene blue, which I then am able to debride back to a healthy bed. Part of my treatment algorithm is definitely to use some irrigation products. I think the evidence for these is pretty moderate, but there's two that I really like. One is this Irricept and the other is Surgifor. These are dilute chlorhexidine and providone iodine constructs. The providone iodine was mentioned earlier. This is actually a sterile prepackaged version. I don't like that these are a little bit expensive and the evidence is not that good for them, but I do use them routinely. Interesting, the intellectual property about both of these products is related to the bottle and not the contents of the bottle. Other solutions, Dakins, which is essentially hypochlorite, peroxide, antibiotic loaded normal saline. There's not a lot of evidence for those. And pulse lavage, I don't use. I just use low pressure irrigation. I do also like to add a sterile surgical scrub brush to mechanically debride tissue further, and I find that pretty helpful. In terms of antibiotics, antibiotics work best when they're culture specific. So a culture negative infection or empiric antibiotic therapy sometimes is not that successful. For me, I'm almost always going to use 6 weeks of IV, often with oral suppression to follow, even in uninstrumented cases. And that could be for 6 months, a year, or beyond if there's extensive instrumentation. And I don't really have oral antibiotic alone as part of my algorithm in the treatment of deep spine infection. But I think in a superficial wound infection, perhaps a stitch, abscess, or something like that, that is not progressing, it could have a role there as well. In-wound antibiotics don't supplant systemic antibiotics and really an adjunct. These were mentioned earlier. For me, this is vancomycin, tobramycin. Gentamicin I don't add, but it's in some antibiotic cements that's preloaded. And then if you have fungus, you can put amphotericin B or voriconazole in there. I use ampho sometimes, and I will also put it in beads. So I'm going to talk about two different kinds of cement that contains antibiotics. So one is polymethyl methacrylate. This is what's used in arthroplasty for hips and knees. And there's two different constructs really that I use. One is beads on a string, the other is as a spacer. There's also a separate image you can see in the top right, which is PMMA loaded cement, antibiotic loaded cement, just kind of covering the hardware. I don't do that. This is somebody else's image, but the beads I definitely will make and will use, and I use that largely to fill dead space. These images below are using spacers both in the pedicle and in the vertebral body. There's a semi-structural component to this, but some of the things that we do to make this elute antibiotic reduce the structural properties of this. And the more antibiotic you add, the more porous it becomes and the less structurally sound it is. So the classic recipe for this is 3.6 grams of antibiotic per 40 grams of cement. I personally don't add that much, but I will use both vancomycin and tobramycin because they're heat stable, and amphotericin if I need to. These nominally also need to come out, although they can be left in indefinitely, but also understand that this is also a nidus for infection to continue to live on because the antibiotic is mostly gone in a functional capacity if you leave these in. Calcium sulfate, I personally don't use because I find these to produce a lot of wound drainage, and there's some evidence to that. But the advantage here is that they can be left in for a long period of time. So you can see an example of beads actually just sprinkled in a wound. You can see them as placed into a disc space. These can also be used as spacers or to some extent even injected. They don't need to be removed, but the high osmotic load definitely does cause a little pause for me because a lot of the other things we're doing also have a lot of osmotic pull, and local antibiotic is highly osmotic. BMP, which I also use quite a bit of in infection and actually really post-infectious reconstruction, also has a pretty high osmotic load. So interestingly, BMP was initially contraindicated for infection, but there is a lot of evidence that's come out that it helps things heal. It seems to enhance vascularity. The evidence, I'd say, is moderate at best, but probably generally pretty poor. But we do know that it does definitely increase fusion in a hostile environment. And so an infection does increase your risk of pseudoarthrosis long-term. And so I will use this post-infectious cases for reconstruction. Vacs and drains, we've talked about a little bit. I love vacs. I use them a lot primarily as an incisional capacity. But if you have a bad infection, I definitely at times will leave the skin open, fascia closed. If I have a bad wound that I've taken out, I'll leave skin open, fascia open. And for those cases where I'm doing something beyond just an incisional vac, I really like a big vac, and it's important to check the canister because they can put out quite a lot. And so even if you have drains in there, these vacs will pull pretty large amounts of fluid out of a wound. And I think it's also really good to just double check that it's not CSF if it looks funny or if your patient's acting a little funny. I use a lot of drains deep and superficial and keep them in for a while post-infection. And if you're really working your way through this list of stuff, at some point, it's a good time to phone a friend and check and make sure you're on the right track, or see if anybody else has any other suggestions. So call a mentor from residency, fellowship, whatever, someone else in practice, call Dr. Spina, call your favorite plastic surgeon. But it's important if you do that, that this is not a dump. So you're not just dumping your patient on them. And this is really something that you kind of have to work on together to get an optimal outcome for your patient. And so for me, I have a great plastic surgeon I work with all the time. We call him the pizza man because he delivers, but he doesn't take everything. And my patients have to be infection-free, essentially. They have to have adequate nutrition. They have to have no plans for an additional procedure. And what he's going to do is, to some extent, going to be up to him. The techniques vary quite a bit. Largely paraspinous flaps, but for the cervical thoracic junctional wound, you could do a trapezius flap or latissimus flap. Down low, you can do a glute flap. You can do free tissue transfer, although I don't think that's really necessary most of the time. And somewhere along the line, you're probably going to transfer this to a tertiary center if you're not there already. And then if all else fails, I think taking out the hardware is a tough call, but is an important thing to discuss as well. So this is a 64-year-old guy. He has a polymicrobial infection. He's had 5 lumbar surgeries. Most of those are INDs. So he's growing fungus, group B strep, and Corynebacterium, which is a pretty bad combination. And he's been on culture-specific antibiotics and has not been very successful. So you can see a large abscess at L5S1 on this image off to the right with a lot of bony destruction. And he got transferred to me for definitive management, but all that really needed to happen was this person that needed to have their hardware out. And so I took out his hardware. You can see his pre-op MRI on the left. And this is a T1 post-gadolinium image. You can see a large posterior abscess and fluid collection, a large really abscess at the L5S1 interspace, and a little bit prevertebral as well. I don't have a post-gad image of him post-op, but this is a T2 MRI sagittal showing really nice resolution of his posterior abscess and abscess at L5S1. I took out the hardware. I did an extensive debridement. I did not close his wound, and I left him with a vac to close because he was pretty malnourished, and he cleared his infection. There are some things I want to talk about next frontier, just to kind of talk about what's out there. And these are other ways to see biofilms. And I use methylene blue. That's definitely one. I think some of these new techniques also are pretty promising. So gentian violet is also another blue dye, and this does stain bacteria and biofilm. This is part of a gram stain, actually. It does have some bactericidal properties, and I think it's kind of interesting and promising. It's not widely used. There is a point of care device, something called Moleculite, which can actually let you see biofilm. And this excites endogenous fluorophores in the bacteria, so you can see them. So MRSA, for instance, is red. Indocyanine green is a dye that also uses light near IR spectroscopy to show necrotic tissue, which is something that needs to be debrided. This has been used in tumors, and there's some ways to use this if you want to. Stryker will help support this. And it is available in some cancer hospitals. So this one's probably a little closer to practice than some of the other stuff. And what's the real next frontier, I think, is local antibiotic infusion and perfusion devices. These really are not existing in the spine space right now, but there's definitely some talk of them for other things in trauma and arthroplasty, as you can see off to the right. And this essentially has an inflow cannular system, outflow cannular system, and is probably going to be coupled with a negative pressure wound device as well. And this would be to perfuse the wound bed with fresh antibiotic in order to keep antibiotic concentrations, because one of the big issues with local antibiotic, whether it's in beads or just sprinkled in the wound, is that it tends to dissipate pretty quickly. And so I think some of these devices will come to market in the next few years, although there's nothing out there right now. So my take-home messages from this are that treatment is really diagnosis specific, depending on the organism, and probably even most importantly, the host, and that antibiotic therapy alone will fail in the presence of biofilm and deep infection. And really, you have to kind of define what your objectives are when you set out to treat these infections ahead of time, and then be willing to do what's necessary to achieve them.
Jeremy, great talk. I think really, really cool work that you're doing with methylene blue, as well as sort of introducing kind of the wave of the future. I think identification of infected areas and being able to know you eradicate the biofilm will be critical to both retaining hardware as well as optimal treatment of these infections moving forward. Just to sort of wrap up the case, and we can answer some questions. One question I have for the panelists, which I think we'll get at Akash's question in the chat, is do you always get an infectious disease consult for your postoperative infections?
I do. I do. I regularly have the infectious disease team weigh in. I think in complicated cases, it can be really helpful for determining not just the treatment antibiotics, but also the length of treatment. And so depending on the risk factors of the patient, retention of hardware, number of INDs, other medical issues, IV antibiotic treatment can range from, 3 or 4 weeks to 12 weeks, most commonly 6, but I think they're helpful with that decision. I also think for following the patients longitudinally, I appreciate having someone else that's helping manage all of their other kind of medical issues related to the infection, if it's antibiotic levels or if it's checking for side effects by getting regular labs, things like that.
Yeah, I do as well. I almost always get an ID consult, and I think they're super helpful because they follow patients long term. A lot of the antibiotics we use are not benign. So you can go into kidney failure. Some of them are hepatotoxic. And for me, it's very helpful to have somebody who's going to know the labs to draw them regularly. Some of the post-infectious surveillance imaging with MRI is pretty helpful as well. And they're just great partners because this really does take a team to resolve some of these infections.
And then sort of the next question that I have for you guys is, I took this patient to the OR. I had planned to do 2 INDs, anytime I see a really, really nasty infection and frank purulence, I always plan to go back a second time, basically until I don't see a large area of frank purulence. The patient was draining on day 6 again after my second IND. And I was planning to take the patient back to the OR for a third IND. I had planned to remove the bone graft and regraft at this time, but do you guys think there's a role for hardware swap? When do you do that? Obviously this is an unstable situation. I could probably take it out for a while. But what are your thoughts in terms of a hardware holiday or a hardware swap?
I mean, I think it's a great plan. So, I mean, it depends how it's going and how the patient is. A lot of this has to do with the patient, what they tolerate, what their social situation's like, how much support they have. To commit somebody to multiple reoperations and, hardware out is a big undertaking. At the same time, it may be what's necessary. So for me, if I'm going to take hardware out, I tend not to do single stage. I think there are definitely some people who do and talk about it in the literature, but I'll usually do that over at two stages. And I may do a decent, pretty significant holiday in between, which gives the infection both time to declare itself and the patient time to kind of declare what kind of patient they're going to be, because I don't always know what they're like if I'm meeting them in the ER or, on a clinic on a Friday afternoon and they're new to me. So.
Yeah, I think for me, if it's a patient that I really feel like I need to do 2 INDs for, that's the patient that I'm most likely to do a hardware holiday in, because I'm already committing to the 2 operations. And I think the physiologic burden of hardware removal and reinsertion is minimal. And so I think that's a great time to do it. I struggle when I think I'm going to do just a single IND, then the role for hardware removal and reinsertion, I think, is much more of a gray area in my practice. And I'll do it mainly based on the chronicity of the infection and the host, but it's very much a gray area.
Awesome. Well, thank you guys. I treated this guy for 6 weeks and then did a subsequent 6 weeks of oral, 6 weeks out from his initial surgery. His CSR was 25, the CRP was 0.3. He healed his incision. And he was doing quite well. I talked to my infectious disease colleagues about when to do the second surgery. They recommended staying on doxycycline. But he's subsequently 2 months out from his second surgery. The wound bed looked clean when I went back in and hooked up to his proximal hardware, and he's doing relatively well. I wanted to thank everybody for participating and attending tonight. Just as looking forward, we're coming to a close here and answer the final question in the chat box. I'm a big proponent of washing my hands with alcohol. I think if you culture tap water, you probably will grow things out. That's my own personal bias. And so I tend to do a pre-scrub early in the morning and then wash with alcohol the rest of the day. I'd like to thank my colleagues, Ryan Spiker and Jeremy Shaw. They gave great talks and provided great insight into the treatment and management of SSI. I hope you guys took something away from this. Just future upcoming webinars, I encourage you guys to attend. Dr. Scott Daffner is doing a webinar on complications and legal ramifications in spine surgery. You likely will be sued at some point as a spine surgery. And so these are always topics to keep in the back of your head, and always great to hear from experts who have been there before. There will be another webinar on August 23rd with the topic to be determined. So don't forget to go to aona.org to register and for more information. And don't forget to fill out your survey tomorrow to gain CME credit. Thanks everybody for attending. Thanks, Jeremy. Thanks, Ryan. It's been a great hour.